Of PhD. Firstly, I will give some background information, focusing on three major conditions such as severe mental illness, self-harm, and suicide. While all these three conditions may seem very different and distinct, they are strongly interconnected and share lots of overlaps in terms of affected population, timing, and risk factors. And firstly, I will explain those interconnections. Here you can see typical human life course, how we commonly see it. But life course of individuals with severe mental illness, self-harm, and suicide is very different from what we used to imagine. And those conditions strongly impact life course of affected individuals. For instance, nearly 50% of psychotic disorders and 35% of bipolar disorders onset before the age of 25. Similarly, 65% of all self-harm is conducted before the age of 35, and suicide is a leading cause of death among individuals aged 15 to 29. Therefore, all these three conditions primarily affect young individuals. But these conditions also have shared impact on disability and premature mortality. For instance, schizophrenia alone is ranked among the top three mental disorders causing the most disability worldwide. Similarly, self-harm is the largest contributor to disability for individuals aged 10 to 24 globally. And both individuals with severe mental illness and self-harm have increased risks of dying from suicide throughout their life course. For instance, SMI individuals with severe mental illness have 10-fold higher risk of death due to suicide during their life course. But these three conditions also share lots of similar risk factors, such as childhood adversities, early life adversity, poor neighborhood, social isolation, and others. And collectively, we call those risk factors social determinants of mental health. And in recent years, lots of studies show that separately, each of these social determinants of mental health is associated with increased risk of severe mental illness, self-harm, and suicide. But we still lack of causal evidence on this matter. Therefore, during my PhD, I am going to focus on specific social determinants of mental health, such as socioeconomic deprivation, neighborhood deprivation, and factors related to social inclusion, such as acculturation, and how these factors causally may impact development of severe mental illness, self-harm, and suicide. But important factors here that all these mentioned social determinants of mental health are overrepresented in certain populations. Social determinants of mental health are disproportionately concentrated in minoritized ethnic groups and migrants who experience increased levels of socioeconomic deprivation and neighborhood deprivation and social exclusion throughout their life course. But also, this group of population experience higher rates of severe mental illness as well. For decades, studies from Europe have been reporting that ethnic minority people 2 to 5 times more likely to develop psychosis throughout their life course. And recent studies have reported increasing risk of self-harm and suicide among ethnic minority and migrant populations. Therefore, during my PhD, I'm going to explore patterns of severe mental illness, self-harm, and suicide across different ethnic and migrant groups, and examining potential explanation for these patterns, such as socioeconomic and neighborhood deprivations and factors related to social inclusion. And during my PhD, I will have three major projects, each focusing on specific mental health outcome, such as severe mental illness, self-harm, and suicide. And today I will primarily talk about my search project dedicated to suicides, because currently I am on data analysis stage for this study. But hopefully next year you will hear more about SMI and self-harm. My project on suicide is based on US data. US data. And in this study, I'm exploring racial differences in suicides and how neighborhood socioeconomic deprivation mediates the relationship between race, migration status, and development of suicide. There are two major reasons why I'm conducting this study in the US. First reason is increasing suicide rates among ethnic minority populations in the US in last 5 years. Which has not been mirrored in other countries. While there is decrease among ethnic majority population, which has also not been mirrored in other countries. And the next reason is availability of detailed state-level data on suicide in the US, which is collected by CDC, and this data set is called National Violence Death Reporting System of the United States, where they collect information on suicide from three major sources, such as law enforcement reports, medical examiner and coroner reports, and death certificates. And currently, this data set includes 50 states, the District of Columbia, and information on some US territories as well. For this study, I'm using suicide data, and I'm going to merge it with American Community Survey data, providing demographic information and information on neighborhood level socioeconomic factors. And my suicide data set initially included all suicides for the period from 2003 to 2021. And it includes not only suicides, but all types of violent deaths, such as suicide, other violent deaths, such as homicides, or deaths due to legal intervention, as well as or death of undetermined intent. And after data cleaning and identification of suicide cases based on ICD-10 codes, my final population includes all individuals conducted suicide from age 10 for the period from 2011 to 2021. And this period has been chosen due to availability of neighborhood level information in American Community Survey only from year 2011. And my final cohort includes 268,141 suicides. And here you can see characteristics of my study population. In general, you can see that age-adjusted suicide rates tend to be the highest among American Indian and Alaskan Native population, followed by white and Native Hawaiian or Pacific Islanders. In general, we can see that age-adjusted suicide rates tend to be the highest among indigenous population of the US. When it comes to sex differences, across all racial groups, suicide rates tend to be 3 to 5 times higher in males compared to females, which align with other studies reporting higher rates of suicide among men compared to women. Here you can see age-adjusted suicide rates by race for my study period. And as you can see, nearly during the whole study period, suicide rates tend to be the highest among American Indian and Alaska Native population, followed by white. But the major thing here is that suicide rates in last 5 years tend to increase among ethnic minority populations such as American Indian and Alaska Native and Black or African American, while it was quite stable or decreasing among white population. In the next table, I will show you incidence rate ratios for the two major periods, for the period from 2011 to 2016 and from 2016 to 2021. For the first period from 2011 to 2016, we can see increasing suicide rates for all racial minority populations, such as American Indian and Alaska Native, Asian, and Black population. But we should be very careful in interpreting these results, as data availability and completeness of data for states was the lowest for the period from 2011 to 2016, reaching only 43%. But for the period from 2016 and 2021, the data completed was over 80%, and still we see here increasing suicide trends among ethnic minority populations such as American Indian and Alaska Native, as well as Black or African American. And this increase for Black population was substantial. And overall, during the study period, we can see increasing suicide trends among racially minoritized population in the US. And the next step in my study is merging my suicide data with neighborhood level socioeconomic information from American Community Survey. And currently I'm extracting and merging employment, education, and poverty data. And the next step is to explore how neighborhood level socioeconomic factors might impact the development of SMI suicides among racially minoritized groups in the US. My first and second projects will be dedicated to SMI and self-harm, but today I'm not going to talk about these projects a lot. I just want to mention that I already have access to my data for this project, and this project is going to be based in the UK, and for this study I'm using eChild dataset, which is a dataset on children and young people born in England from 1984. And basically this data set is a mix of medical records and educational records of children and young people in the UK, which allows me to explore both neighborhood socioeconomic factors and factors related to social inclusion.
Okay, I think we're going to need to wrap up now.
Yes, thank you. And take home message from my presentation is that social inequalities and social determinants of mental health shape the development of serious mental conditions such as severe mental illness, self-harm, and suicide. And I hope that my study will make some impact on understanding this matter better. Thank you for your attention, and a huge thanks for Mental Health Research UK and my supervisory and series committee team for supporting my research.
Right.